Hello, everyone. My name is Alberto Avila, geriatrician at the National Institute of Medical Science and Nutrition, Salvador Subirán in Mexico City, and I have the pleasure to chair this symposium dedicated to COVID-19 and mental health. Thank you to all of you for your interest in this topic, and I appreciate you joining us. The world has known the first great pandemic of the 21st century. 2 years ago, our way of living changed completely, and we experienced unprecedented phenomenon and health actions. The new disease called COVID-19 particularly targets the most vulnerable persons, such as the older adults. All of us witnessed the COVID-19 related infodemic, as well as the terrible consequences for everyone in our society. Controlling the spread of COVID-19 target many public health measures that include social isolation. Before the COVID-19 pandemic, it was already known that social isolation measures are associated with a set of adverse health-related problems, including mental health. Therefore, it was potentially expected that in an already vulnerable population, some of the mental health complications associated to social isolation could increase because the adoption of lockdown periods to limit the spread of SARS-CoV-2 as the World Health Organization warned at the beginning of the pandemic. In this sense, older adults are not only in higher risk for increased mortality from COVID-19, but also are vulnerable for adverse mental health effects, such as development of depressive symptoms of cognitive decline. Recently, multiple projects have been conducted in order to study the impact of the diverse lockdown periods may have had on older adults' mental health. Results coming from the early months of the pandemic and the first lockdown periods have been very heterogeneous, either because they did not observe changes in mental health during that period, or because they reported a worsening of mental health problems. Since the future of the pandemic is still uncertain, it is pertinent to continue studying the possible association between isolation and its negative mental health related consequences. The symposium wants to present some examples of the mental health problems caused by the COVID-19 pandemic, particularly in Mexico and France. While there is a growing body of information on the consequences for mental health in high-income countries, little information from developing countries is available concerning the potential effect that the first lockdown period may have had on older adults' mental health. In Mexico, in order to limit the number of infections by SARS-CoV-2 between March 23 and May 30 in 2020, strict social distancing, domiciliary lockdown, for example, as well as the suspension of all non-essential activities were recommended by the government. Therefore, the objective of the present symposium is to present the effects of loneliness and social isolation during the first wave of the COVID-19 pandemic. It was to see if there are cross-cultural differences in attitudes towards health measures taken during the pandemic period, and finally, to explore the trajectory of cognitive decline or the cognitive function before and after the COVID-19 pandemic. I thank my colleagues and friends from Mexico and France for their participation in this symposium, Dr. Sara Aguilar and Dr. Virgilio Hernandez from Mexico, and Professor HÉLÈNE AMIEVA from France. At the end of the presentation, we will have a round of question and answers. So I invite you to stay with us, and thank you for your attention.
Thank you for the presentation, and thank you for the invitation to organizing committee and Dr. Avila Funes for the opportunity to present the result of this work. It's an honor to share this symposium with Dr. AMIEVA and Dr. Virgilio Hernandez. The title of my presentation is Association of Loneliness, Social Isolation, and Daily Cognitive Function in Mexican Older Adults Living in Community during the first wave of COVID-19 pandemic. Cognitive impairment constitutes a major determinant for middle and older aged adults' health, functionality, and well-being. It's indeed a critical hallmark of neurocognitive disorders, such as dementia. As a result, major efforts are being directed toward to identification of the factors that may contribute to cognitive decline, prevention, and risk reduction. Social determinants as a potential risk factor for cognitive decline, and these have gained increasing attention. Loneliness and social isolation are associated with increased morbidity and mortality. Deeper understanding of neurobiological mechanisms underlying is needed to identify potential intervention targets. The COVID-19 pandemic is associated with several short and long-term negative impacts of the well-being of older adults. Physical distancing recommendation to reduce transmission of the SARS-CoV-2 virus increase the risks of social isolation and loneliness, which are associated with negative outcomes, including anxiety, depression, cognitive decline, and mortality. Our objective was to understand the influence of loneliness and social isolation and in daily cognitive function in a sample of Mexican older adults living in the community during the first wave of COVID-19 pandemic lockdown and assess characteristics associated with loneliness. This cross-sectional study derived from the cohort the impact of COVID-19 on well-being, cognition, and discrimination among older adults in USA and Latin America. 14 countries participate, Mexico participate too. For this study specific, we include participants who reside in Mexico during the first 6 months of lockdown, March to August 2020, those who complete the survey online, which was conducted in Spanish. All participants gave their consent online, be included, and this study was approved by the Institutional Ethics Research Committee, the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán. Our variables. Daily cognitive function by everyday cognition scale ECO was measured. Other questionnaires, for example, the 7 memory questionnaire about the subject memory complaint, social isolation, loneliness, and sociodemographic and clinical variables were included: sex, age, marital status, years of education, working status, self-perception of health, drugs, and comorbidity. The John Gerber Loneliness Scale measures emotional and social loneliness by 3 items each, which a total of 6 items for general loneliness. Participants select an answer from the 4 options, which are yes, more or less, no, or no answer. Social isolation by the Epidemic Pandemic Impact Inventory, EPI, is a questionnaire developed and designed to assess the personal impact of coronavirus pandemic in various domains of personal and family life. The 7 memory questionnaire was being validated to assess cognitive change in older people. An answer consists of yes or no according to the subject memory complaint. To determine the association between loneliness, social isolation, and subject memory complaint with ECO, the participants were categorized using a cutoff point of 1.31 below by ECO, indicate normal cognition. And finally, we use multivariate linear regression adjusted for potential confounding variables to determine the association. Our results. 308 participants were included. 75 were women with a mean age of 65 years old. 8.4% report COVID-19 symptoms. Most subjects were married, civil union near 50%. Those who live alone were distributed with the following groups: single, widowed, and divorced, or living alone. The average years of education was 15. In terms of occupation, most participants were retired, followed economical active people, and finally, housewives. 84% had loneliness, while 40 of the participants identified themselves with social isolation using the EPI scale. On the other hand, the ECOG total score was 57.6 and average score 1.4. With the highest score for these cognitive domains were memory, 14, language, and finally, visuospatial processing. In this slide, using the cutoff point suggested by Van Harlet et al., 49% had a score 1.31 below, indicating normal condition, while 41% had a higher score corresponding to cognitive impairment. The perception of loneliness was higher in the second group, as well as social isolation and subjective memory complaint. And finally, demographic characteristics were similar in both groups. Finally, in this slide, we describe the multivariate regression model adjusted. We show a negative and statistical significant association with loneliness and social isolation with ECOG, while subject memory complaint had positive association with ECOG. This model explained the 15% of the variability of the ECOG score. Our conclusions. During the first wave of the COVID-19 pandemic in Mexico, we found a negative and statistical significant association with self-perception of loneliness as social isolation and daily cognitive function. Loneliness and social isolation have impairment in daily cognition function, which strongly suggests the need to increase vigilance of those identified with this condition resulting from the deleterious effect on cognition. Finally, the SARS-CoV-2 pandemic brought multiple challenges, but also valuably lessons for the clinicals. Regarding cognition, it was possible to recognize latent but forgotten risk factors, loneliness and social isolation. A better understanding of this phenomenon will allow to the development and adaptation of evidence-based intervention to address and prevent its impact on cognitive decline. That's all, and thanks for your attention.
Thank you very much for the invitation to this symposium. I'm really happy to present this work on behalf of the laboratory in France at Bordeaux and Mexico City, Mexico. I have no potential conflict of interest to report for this presentation. So, as we all know by now, the older adults represent a group disproportionately affected by the pandemic and some of the measures taken against it, like the different lockdown periods, not only to direct disease-related outcomes, but also to the potential psychological and mental health-related outcomes. However, and maybe paradoxically, the available literature from the first months of the pandemic may draw a mitigated picture of the psychosocial effects of the initial lockdown period in older adults. Nonetheless, the studies conducted so far are mainly based on web-based surveys from high-income countries that share relatively similar sociocultural factors. And as we all know, sociocultural factors, or the social determinants of health, may not only impact on COVID-19 related outcomes, but they may also have an influence on the psychological and perceived experiences, or how the older persons faced the crisis, or how they fared with the measures adopted against COVID-19, like the different lockdown periods. So, by comparing the initial results of two surveys with a similar design, they shared the same questionnaire, and they were aimed at communitarian older adults and were conducted in parallel at Bordeaux in France and Mexico City, Mexico. The objective of this work was to determine to what extent the cultural and economical environment influenced how the older adults experienced the first months of the COVID-19 crisis, and particularly the first lockdown period. For this, the PACOVID, the Older Persons Phase 2 COVID longitudinal survey, was developed during the first days of the first lockdown period by Professor HÉLÈNE AMIEVA at Bordeaux. And this has the advantage that this survey was built within the framework of 3 ongoing longitudinal studies on aging at the southwestern region of France. And that these populational surveys, they also have the advantage that they include a large spectrum of participants, and they have participants from rural and urban areas. So the participants that were still followed up within these cohorts were contacted by trained staff and were invited to complete the survey. The telephone was privileged over the internet to promote the participation of oldest persons, socially isolated individuals, people in poor health conditions, and persons without access to the internet. A vast amount of variables and health-related and mental health-related domains were collected. I'm going to present you over the results of these different domains. And likewise, a Mexican counterpart of the survey was performed. This was the PAM-COVID sample. The participants for the Mexican counterpart were the older adults that were followed up by the geriatrics outpatient service of the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán in Mexico City, and whose consultations were postponed due to the first lockdown period. I'm going to present the results for the first wave of both surveys, the between sample comparisons and the performed logistic regression models to assess the association between sample and the given answers, being Mexico the reference category. Beginning with the participants' characteristics and living conditions during the lockdown period, we had 467 participants at the French sample and 199 participants at the Mexican sample. The French sample had a higher age. We observed a mean age of 87.5 years for the French sample and 82.2 for the Mexican sample. That was statistically significant. Likewise, we had a higher proportion of women that responded to the survey at the Mexican sample. We did not observe differences for the different educational levels, nor for disabilities, but the presence of one or more disabilities of basic activities of daily living. However, we did observe a higher proportion of participants with at least one disability for instrumental activities of daily living and at least one comorbidity in the Mexican sample. Continuing with the characteristics and living conditions, despite a statistical significant difference, the majority of participants from both samples stayed at their home during the initial lockdown period. However, almost half of the French sample reported being living alone over that period of time, and almost 70% of the Mexican cohort sample reported being living with another family member or with another person. We need to state that intergenerational households are a really frequent phenomenon in Latin America. And maybe we can also see that at the reported number of persons living at the same home and the proportion of children at home for the Mexican sample. Beginning with the psychological experiences during the lockdown period, the first category that we're going to see are the main perceived difficulties during the initial lockdown period. Despite a difference at the answer being word for which a higher proportion of participants reported as the main perceived difficulty in the Mexican sample, Relevantly, no differences were observed for almost the whole list of main perceived difficulties experienced during the lockdown period, as none being in lockdown and social isolation represented the main answers for both samples. However, we did observe two comparable answers, as economic concerns were reported by 3% of the Mexican sample, and the stop of leisure activities was reported as the main difficulty in 2.8% of the French sample. Advancing to the reported coping strategies, at a glance, we may observe that there are several differences between the samples. However, if we look closely, the strategies of distraction, the maintenance of daily activities, and compliance of safety measures as coping mechanisms represented the main reported answers for both samples, almost in the same proportion, leaving acceptance of the lockdown situation with a higher proportion in the French sample, and maybe not surprisingly, religion as a coping mechanism in the Mexico sample as differences. No differences were observed for subjective health, as good and average represented the main answers for both groups, nor for the questions that we used from the CESD questionnaire for the feelings of sadness, depression, and loneliness, as never and very rarely and occasionally represented the main answers for both samples. Advancing to social support and digital tool used, we did observe the important differences. Maybe as expected, a higher reported frequency of structured domiciliary health services and being contacted by city services was observed in the French sample. However, and interestingly, a higher proportion of digital tool used was reported in the Mexican sample. A working theory on this is that maybe the exposition to the intergenerational household maybe exposed the participants to newer technologies. So, and maybe this is the most important part of the work, no differences were observed for the reported perception of social support. The majority of participants from both samples reported the feeling of being socially supported, nor for the number of calls received from family and friends over that period, and a positive perception towards newer technologies, as they reported, or the more frequently reported answer from both samples was that the digital tools help more respect to a classic call. Advancing to attitudes and representations towards the pandemic, no differences were observed when we asked them if the proposed measures were adapted for the situations, whether if the measures could protect them against COVID-19, if the proposed measures against COVID-19 should be respected, and whether if they would accept the vaccination if it was already available over that moment of time. And yes, without a doubt, represented the more frequent answers for both samples. Finally, for the knowledge of the pandemic and sources of information, despite a statistical significant difference, keeping informed of the situation by watching the TV was the more frequent answer for both samples, and no differences were observed for the knowledge of protective measures against COVID-19. The majority of participants had good knowledge with respect to the lockdown measures, physical distancing, and hand hygiene. And they felt, the majority of participants felt completely able to adopt them. So, concluding, what we did observe was a vast amount of similarities in the responses between the two groups. And despite distinct social, cultural, and economical background, the experiences of older adults during the first lockdown period in France and Mexico seem to be comparable, with certain nuances. With relatively similar perceptions of the pandemic and adaptive abilities to face the situations, which highlights, importantly, the relatively good resilience capacities of older adults, whatever the socio-cultural and economic context. Thank you very much for your attention, and I would like to thank Professor AMIEVA and Dr. Avila for the support and having the vision to perform this work. Thank you very much.
Hi, I'm HÉLÈNE AMIEVA, and the title of my presentation is Trajectory of Cognitive Decline in Older Adults Before and After the COVID-19 Pandemic. It may be unusual to start a presentation by presenting methods, but it may be important to understand the genesis of the PACOVID project on which are based the results I will present in this talk. For many, many years, we've been conducting several prospective cohort studies on older adults selected from general population in the region of Bordeaux, France. Each of these studies has some specificities, but they all rely on more or less the same methodological design. They involve older adults aged 65 and over at baseline who were randomly selected from general population. Each 2 to 3 years, face-to-face interviews, including functional and neuropsychological assessment, are made at participants' home by trained psychologists. And for those participants suspected of presenting neurological disorders, a neurologist or geriatrician comes and visits to provide a clinical diagnosis. Several years and even decades after the baseline, these participants are, of course, far fewer than they were at baseline, and those still alive are now 85 and over. When the COVID pandemic started, and more particularly when the first national lockdown has been decided by French authorities, our research team rapidly decided to set up a phone survey in order to figure out how older adults were dealing with this particular and stressful situation. The survey consisted of a first wave that took place during the first lockdown, that is in April 2020, a second wave that was carried out about 5 to 7 months later, and a third wave that was conducted 16 to 18 months after the first wave. The interview was conducted by phone by trained psychologists and explored the living conditions, coping strategies, anxiety and depressive symptoms, health status, functional status, social support, digital tools use, knowledge about the COVID-19, and knowledge about the recommendations and policy measures taken in response to the pandemic. This survey is called the PACOVID survey. It has been funded by the National Agency of Research and aimed at addressing the following questions. First, what are the attitudes, the psychological and social experiences of the older persons with regard to the COVID pandemic and the lockdown measures? What was the level of stress, the coping strategies used, social support, access to information, the representations of the pandemic, and so on? Second question was, to what extent will these characteristics, representations, and attitudes impact their mortality and health? And a third objective was to assess potential social cultural differences in the way older adults live this critical period. As a similar survey was carried out in Mexico, this part of the study is presented in this symposium by Dr. HERNÁNDEZ-RUIZ. What do we know about the way older adults lived the pandemic period from a psychological point of view? Actually, several studies, most of them web-based surveys conducted during the pandemic, suggest that older adults exhibited less anxiety and depression symptoms than adults in younger ages. Some of these studies are mentioned in this slide. I won't detail these studies, but they consistently reveal that indicators of mental health measured in the elderly during the outbreak are less impacted than what may be observed in younger adults. This is also what we found in the participants involved in the PACOVID survey, as when they were asked about during the lockdown, what is the major difficulty you encounter? The most frequent answer was actually known. Nearly 36% said they had no particular difficulty. It seems that they found quite efficient strategies to cope with the situation. Distraction and maintaining activities of daily living being the most frequent coping strategies used. And when they had to assess their own health, about 60% considered their health as good or very good. Similarly, only 13% reported feeling sad. Only 10% felt depressed, and about 20% reported feeling alone. Anxiety was a little bit more silent, as 27% felt high level of anxiety. And finally, a huge majority, 92%, reported being socially supported, which is quite a lot. Therefore, like other studies, our results also claim for a weakened impact on mental health, even though the participants were well informed and concerned about the COVID outbreak. So to a certain extent, the oldest old were able to adapt and to endure the situation. As oldest old generally present reduced mobility and only go out for specific reasons, the stay-at-home order may have had less impact in younger populations who used to go out more frequently. Now, what about cognition? Can we draw the same conclusions, that is, a low impact on cognition? Well, a few studies have been conducted in patients with cognitive disorders and support the hypothesis of an accelerated decline. Like this study by Gunn and collaborators comparing the slope of decline in two groups of patients with neurocognitive disorders, including Alzheimer's disease. One group assessed during the pandemic and another group of patients assessed in a non-pandemic period. Zapano and collaborators interviewed 204 caregivers of patients with Alzheimer's disease who reported a greater cognitive decline during the pandemic in the patients. And Ismail and collaborators reported an accelerated cognitive decline in older adults with Alzheimer's disease living in institution. These studies have focused on patients with cognitive disorders. Very few studies have been conducted in older adults living in the community. Ingram and collaborators investigated about 350 older adults aged 18 to 72, repeatedly assessed 13 weeks during the pandemic with online cognitive tests. They reported a cognitive decline mainly in socially isolated persons. The study by Noguchi and collaborators is based on a survey of 955 community dwelling older adults living in Japan who completed a postal mail questionnaire. Perceived cognitive decline was self-reported by some participants, not all participants, and in particular those presenting social isolation. Finally, Depew and collaborators in Belgium used an online survey in 600 older adults and found a negative impact on well-being, sleep, leisure activities, and cognition, particularly in those older adults with depressive symptoms. Although interesting, these studies suffer from important limitations. Some of these studies include young participants, like the first one. Other studies include participants with very high socioeconomic status, as the authors themselves underline. Also, they rely on poorly validated tests or questionnaires. But above all this, the main limitation is that there is no objective measure of cognition and no pre-pandemic measure is available. So all in all, there is no population-based study addressing cognitive decline in older adults assessed with objective measures of cognitive functioning and comparing the cognitive performances measured during the pandemic with pre-pandemic cognitive measures. So taking the advantage of the PACOVID survey, which is based on ongoing prospective studies, as I mentioned earlier, we use the data collected during the pandemic to estimate the potential impact of the pandemic on older adults' cognitive status, considering their cognitive trajectory before the pandemic. If you remember, the PACOVID survey consists of 3 successive waves and relies on a phone interview. Cognitive tests designed and validated for phone administration are not that many. The TICS telephone interview for cognitive status is one of these tests. At the second and third waves, the TICS has been proposed to participants. For this study, the present study, I'll only present the results obtained during the second wave of the survey, as we are currently analyzing the data of the third wave. During the preceding follow-up visits made in the framework of the cohort studies, several tests have been repeatedly administered, among which the MMSE. As you may guess, the TICS was not part of the test proposed since the visits were completed at participants' home. However, the MMSE and the TICS share common characteristics. First, both tests were designed to provide a global measure of cognitive status. And still more interestingly, 11 items are exactly the same in the 2 tests. These items are: what day of the week is it? What is the day today? What is the month? What is the year? What town are we in? The 5 items requiring subtracting 7 from 100 and so on, and repeat no ifs, ands, or buts. Thus, based on these 11 common items, we computed a proxy of cognition that we could compare before and after the start of the pandemic. Regarding statistics, very briefly, in order to investigate potential accelerated decline after the start of the pandemic, a latent process mixed effects model was conducted, allowing analyzing longitudinal data and testing a significant change in the slope. The effect of age and the effect of the cohort on the slope of decline was statistically assessed by the model. This table displays the characteristics of the study sample briefly. The mean age of the participants for the whole sample, including participants from the 3-city study and those coming from the AMI cohort, was 88 years. There were slightly more women than men, 59% versus 41%. Regarding education, the distribution was relatively well balanced, with a substantial number of participants in all categories, from very low schooling to very high level of education. And finally, the mean TIC score for the whole study sample was 28.4. On this slide, you can see the curve of the cognitive score evolution along the follow-up period considered, including the PACOVID follow-up and the 5 preceding visits made in the framework of the cohort studies. The visual inspection of the curve suggests an acceleration of decline concomitant to the pandemic. Is this confirmed by the results of the mixed model? Yes. First, the results show little and actually non-significant decline in the cognitive score before the pandemic, that is, during the follow-up of the participants in the cohort studies. But when considering the pandemic time within the follow-up, a negative and significant interaction is found, which means that after the start of the pandemic, the decline is significantly greater. The results show that the interaction between time and age is not significant, meaning that the age has no effect on the shape of the curve. The model also assessed the potential effect of the cohort, and it was important to ensure that the results observed were not specific to one of the cohort studies, but are similar in the two populations. Now, it may be seen, the interaction between time and cohort is not significant, which means that the cohort has no effect on the shape of the curve. So, to summarize, we examined the cognitive change of older adults due to the COVID outbreak in a sample of French older persons living in the community. Compared to the slow and non-significant decline of the cognitive score all along the almost 15 years preceding the pandemic, we found that the rate of decline about 5 to 6 months after the start of the pandemic is far greater, with a highly significant change in the slope of decline. This finding is consistent with what could be extrapolated from the various core studies available that I mentioned earlier in this presentation. However, this is the first study that reports such a finding based on a design allowing comparing the trajectory of decline before and after the pandemic. With the current pandemic, individuals underwent lifestyle changes that disrupted the social functioning and daily routines that are essential to promote mental health in older adults. Such abrupt changes in daily and social activities which persisted over time may have negatively impacted cognitive functioning and are potentially harmful for future cognitive decline. Now the question is this cognitive decline just temporary in reaction to the crisis? Or will the evolution be reversed in the next months or years? Or will it continue to worsen with the pandemic, which is not completely over? This is an issue with obvious public health and clinical implications. The currently ongoing follow-up of the PACOVID survey may provide some clues, hopefully, but more generally, the COVID research in older adults needs to pay a very special attention to cognitive outcomes. This is our research team in Bordeaux, and here are listed some articles from the PACOVID survey that have been already published. Thank you for your attention.
Hello, everybody. Thank you for joining us at this symposium dedicated to mental health and COVID-19. And I thank you to Dr. Sara Aguilar, Dr. Virgilio Hernandez, and Dr. HÉLÈNE AMIEVA for accepting to participate with us this morning. And thank you for choosing and follow us at this symposium. And we have a few questions about this interesting discussion. And in the first presentation, we heard Dr. Aguilar talking about the isolation, loneliness. And the first question, it's for Dr. Aguilar, is isolation has been recognized as a risk factor for cognitive impairment for less stimulation. But in loneliness, what will be the mechanism? What will be the mechanism for the loneliness? Or what would be the differences between loneliness and isolation?
Okay, yes, thank you, Dr. Avila, for the question. Yes, in this study, we take it's a remote survey in older adults living in the community. Do you remember in the first wave of the COVID-19 pandemic in Mexico? But the mechanisms that explain how loneliness impact on cognition and is specific in the relationship with chronic stress. Increased glucocorticoids activation and hypercortisolism. These physiological alterations occur in different dependent of the loneliness period. If you have a transit loneliness, can active, for example, the hypothalamic pituitary adrenal axis to negatively regulate inflammatory response, while if persistent loneliness is associated with increased production of pro-inflammatory cytokines, such as tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, among others. These states of chronic inflammation decrease dopamine signaling, circadian rhythm, and monoamine levels, for example, serotonin, norepinephrine, and dopamine. And that's turn in synaptic plasticity and neuronal survival decrease. I think this phenomenon increased neurodegeneration. I think loneliness and social isolation increase. We need increased attention. Who have loneliness isolation, it's a potential deleterious effect on cognition function.
Okay, thank you. Thank you for the answer. Hélène, maybe some words, or it's okay?
I think you asked the question, what was the difference between loneliness and social isolation. To complete the answer provided by Sara, I would say that one important point to get is that feeling of loneliness is a subjective feeling of being alone. You can have some people around you, but you can feel alone because these people do not provide the support that you expect. So feeling alone is a subjective feeling, while social isolation is the objective social support, the number of people you have around you. So it's kind of subjective and objective social support between the two dimensions.
Yes, agree.
Okay, thank you, Hélène. And we have another question, and the question is: it is possible, this is for Virgilio, Dr. Virgilio Hernandez, it is possible that older adults already live in isolation, in social isolation, in both countries, and that was the reason why there are no differences between countries in issues such as the perceived social support, for example?
Thank you very much, Dr. Avila Funes, for the question. That's a really interesting question. The result was a low feeling of a majoritarian proportion of participants saying that they felt socially supported. That was the outcome. Both samples arrived by different means to that same conclusion. The participants from the French sample had that outcome because the people that were around them contact more frequently. The people that were around them adopted different postures, like performing their groceries. They helped them with their medicament, with their treatments, and they helped them with the pharmacy. So they had different mechanisms to compensate the differences precisely between the two countries by different mechanisms or adapting by different mechanisms. Maybe they arrived at the same outcome, which was a feeling of social support.
Okay. Okay, thank you very much. And we have another question for Dr. AMIEVA. And the finding of cognitive decline is remarkable. What strategies should we do to prevent it? How to identify the vulnerable people for this?
Well, thank you for this question. I'm not sure I will provide the right answer. I don't have the solution. I think that the most important message of this presentation was that we really have to matter about cognitive issues in this pandemic. Of course, all elderly people have been seen as a group at risk because they, as you all know, present higher risks of mortality, but they should be also seen as a group at risk because they're susceptible, they're likely to present an accelerated decline too. So I don't know exactly what is the solution, but I think that the measures adopted by most countries that resulted in reduced social contacts are, of course, measures that can be justified. And I think the most evident, the most obvious was to adopt these measures. But on the other hand, these restrictions, these drastic changes in social functioning have probably led to fewer cognitive stimulation, actually not only fewer social stimulation, but probably cognitive stimulation, which resulted in this accelerated decline. So if in the perspective of other episodes, maybe we should find a good balance between protective measures, but also measures that allow people, elderly people, to maintain a certain level of cognitive functioning, even though.
Okay. We have another similar question for Dr. Aguilar. Dr. Aguilar, what strategies could we have applied during the pandemic to prevent loneliness and social isolation and its outcomes in cognitive decline?
Okay. Yes, it's a difficult response because I think there are many factors around the isolation or around the loneliness. Another aspect is comorbidities. In our experience, many patients lost to continuous medical attention, and maybe that factor increase the cognitive decline. And of course, the cognitive stimulation by socialization or maybe about the I'll leave maintain functional activities is very important. Maybe do exercise, do take medications, and of course the regulates to medical situation. I think it is the same, but we show like studies of HÉLÈNE AMIEVA in the memory clinic. We look a decline in our person with MCI or with dementia. It's an interest phenomenon, and maybe we increase the aspect, sociodemographic aspect for the decline, cognitive decline. Thank you.
Okay, and we have another question for Dr. Hernandez. It's Dr. Hernandez, didn't you measure health literacy in the participants? Do you think it will impact knowledge on preventive measures?
Yes, that's maybe I can use some help from Professor AMIEVA, but we did not directly evaluate health literacy on the participants for none of the samples, the French sample nor for the Mexican sample. I do believe equally as the person that made a question that health literacy may play a direct role precisely for knowledge about the protective measures. But alas, one of the, I would say, or I would dare to say, some of the richness found on both samples, despite that we didn't directly evaluate health literacy, the knowledge about the protective measures was high in the two samples, despite the context in the Mexican and the French group. So, but the direct answer was no. No, we didn't evaluate it, and yes, it could play on the outcome. I don't know if Professor AMIEVA would have something to say.
No, I think you provided the correct answer. I do agree health literacy would have been an interesting variable to measure, but what we found is that, as you said, Virgilio, that we found that the knowledge about the pandemic, the measures adopted in response to the pandemic was very, very good in both samples. So actually, even though there is a potential difference between health literacy, it may not explain why there isn't a difference, because there is no difference actually in the way participants were aware of the pandemic and the health sanitary context.
Okay, and we have now 2 minutes. And for the results and for your results, do you think that this is a new isolation or social isolation, or is it a cumulative problem?
I think it's a accumulation situation. It's more difficult to differentiate between depression and loneliness, for example. But some studies include longitudinal studies or cohort studies to show the difference between loneliness and depression. And social isolation, I think, is another factor for determine the effect of cognitive decline, for example. On the other hand, we show difference between persons who have COVID-19 and have a manifestation or problems about long COVID, and persons who don't have COVID and only have a social isolation, for example, or loneliness. And I think this difference is very important between situations.
Okay, we have maybe the last question. I'm sorry, from UK. The panel have present evidence on the indirect effects of the pandemic, but are there also effects from COVID-19 and long COVID-19 on the health of other adults? For example, brain fog. Maybe a little answer.
Dr. Aguilar wants to.
Okay, come on, Virgilio, please.
For our results, for the first results were during the pandemic. So, and the second results that Dr. AMIEVA presented were during precisely the description of long COVID. I think that to answer that question directly about the long COVID or brain fog after COVID, the studies need to include the variables directly posed to evaluate long COVID.
Okay. Well, the time is over. Thank you very much, Dr. AMIEVA, Dr. Aguilar, Dr. Hernandez, for your participation, for accepting to be with us and to share your experience in this Congress, World Congress of the International Association of Gerontology and Geriatrics 2022, and I'll see you later. And thank you all of you for joining us and follow us. Thank you. And you remain for the question after.
Thank you very much. Thank you.